Welcome everyone. So uh, I have made other participants as host so that they can admit people who are coming, because it's very difficult to keep on admitting people. Because so Dr. Aparna, please admit people who are joining late.
Okay, sir. Good evening, sir.
Good evening. Good evening. So very good evening to all of you. So today we'll be discussing like how we should examine retina during the exam. So I am Dr. Koushik Tripathy. I am a retina consultant at ASGI Hospital, Kolkata, India. I uh, I am a faculty member at Muthuswamy Virtual University of Postgraduate Ophthalmology. So I have no financial interest to declare, and I sincerely thank my fellow Dr. Aparna Bose and Dr. Koushik Dr for helping me in this presentation. And I am thankful to Professor Palaniswamy Muthuswamy, Vijay Paranjpe ma'am, Dr. Ghada ma'am, and the faculty members and all the members of MVUPGO. And I am also grateful to Dr. Ramnath Bhute sir for his enlightening philosophy. So, what are the philosophy? So, try to be like a swan, try to take out what is suitable for you, and do not argue. Try to take the best out of everything and leave the rest, leave the things which are not suitable for you. And when there is a donut, focus on the donut and do not focus on the hole which is inside. That means focus on things which you have or things which are in hand, and do not focus on or be anxious over the things which you do not have. And also be a half glass or empty glass so that you can take more. If you feel that you know everything, then there is no chance of improvement, and no chance of gaining more knowledge. So with that, if possible, you can turn your on your video, and please mute if you're not speaking. So I'll discuss direct ophthalmoscopy, indirect ophthalmoscopy, and slit lamp biomicroscopy. So these are very important topics. So basically, I'll discuss the principle of each instrument or each technique, and the main important things which the examiners will see, that you have to show courtesy to your patient and examiners, and also the helpers who are there, the fellows or other doctors who are helping you. And if there is a if the A is given, you have to wash your hands or clean your hands. Dark room is very important. If you do not darken the room, then it is a very high chance that you might fail. Though if you are very uh, experienced in doing things, you may be able to see the fundus in enlightened room also. But definitely ask the people who are there to darken the room. This is very very important. And also, before using an instrument, check if the instrument is working okay. So this will come when you have practiced a lot with the same instrument, and you will know what is problematic. Even the if the instrument is not working well, you will have the ability to solve the problem before you see the exam. The challenges are that if you want to follow a specific routine, you may not be able to follow, because there is very less time. And if you want to greet patient, wash hands, and do everything which is per protocol, then you might get very less time to examine the patient. So that is also, the examiner might not allow you to talk or communicate with the patient directly, but your body language also shows your attitude. So be very maintain courtesy to the patient, and uh, just thank them, because they are helping you in the exam, and it is very difficult to tolerate this bright light again and again. So I'll come to direct ophthalmoscopy directly, because most of the people are not using direct ophthalmoscopy as of now in clinics also. But you need to practice it. At least do it in 100 patients, because direct ophthalmoscope is usually not given, but it is an essential skill, and it can be given. If you say that I have not used direct ophthalmoscope again ever, so you will definitely fail. So, what does direct ophthalmoscope do? Basically, direct ophthalmoscope is a just a simple mechanism to illuminate the retina and see the retinal image at the same time. The light is like uh, the light there is near coaxial illumination, and because of this, there the light reflex of the from the cornea can make these things difficult. And if there is a refractive error for patient or an examiner, you'll have to compensate that. There is a dial in the ophthalmoscope, and so this becomes very difficult if you have not practiced in very pathological myopes or high hyperopes, aphakic patients. So because the focusing becomes difficult. So that's why you need to see the see the patient when you are entering. See the glasses, whether the glasses are thick, like myopic or hyperopic glasses or not. And also you can check what is called Bruckner's reflex, and that can give you a clue. Any candidate can any candidate tell us what Bruckner's reflex is?
A direct ophthalmoscope is light is thrown onto the patient's both pupil at a time, about
Yes.
50% deep from the eye. So you
Hmm.
will see equal reflex, red reflex on from emanating from both eyes equally. If it is
Hmm.
patient as normal, if there is a dull reflex on one side, then it indicates that there is some media opacities or cataract or something like that. Or if there is an increased reflex on one side, it could be due to a squint.
Hmm. And there might be anisometropia also. It might give
Yeah.
you a clue of this. And also, if there is bilateral hyperopia, also the glow is different. And if there is bilateral high myopia, the glow is different. Try to see, examine, even with indirect ophthalmoscope, you can see the glow. So
Okay,
it will
the arc of reflex will be different in myopia
yes,
and hyperopia.
yes, yes, yes. Thank you, Dr. Emia. So this is one important thing, and before doing like direct ophthalmoscopy, you can do that so that you can get an idea about the refraction which is there. So if the patient has like plus 20 or minus 20 power, then it will be extremely difficult to focus on the retina with direct ophthalmoscopy if you have not practiced it, or if you do not know how to do it. So it gives a virtual erect image, and magnification is very high. So what is the instrument? So this is the instrument. Uh, all of us have seen this. So I'll not go into the details of this. There are multiple spots which are there. So this is the instrument, and this red. What does this red number should mean? Any candidate?
It means minus lenses.
It means minus. Yes, there is you when you start it, you keep it at 0. And these are the various filters which are there: white, green, blue. There is a grid, and if you are starting with small pupil, you can do half like half circle also, and or small pupil. And there is a slit also. You can examine something in cross section. So can anyone tell us why this blue? What is the use of this blue filter?
It can be used with high plus lenses for examining cornea for any aberrations after fluorescence staining.
Yes, also you can, like, if a child is not allowing you to examine, and if there is an history of trauma, you can just put a fluorescein and keep the keep the room dark and put this blue light over the eye. If there is an epithelial defect, it will become prominent. So very good. So this is the grid. What is the use of this? What is this? Can anyone tell us?
This can be used for checking the fixation,
Yes.
eccentric fixation.
Yes. So this is a uh, so this is called visuoscope. So this is not okay. Hello, am I audible?
Yes,
Hello.
Yes,
sir.
sir.
Yes,
Yes,
sir.
sir.
Yes, yes. So this is called visuoscope. Read about this. This is definitely this can be used to check for fixation, eccentric fixation, and also distance from distance of things from a reference point, or the meridian which they are in. So this is, and obviously you can change the color of the light, and also size of the light. So how do you do it? So I'll request all of you to go through this the book by Chua. So this is very important, and the things which it says these are very important in your practice also. So definitely introduce yourself, observe for any external sign, as I told, like see for any nystagma, see the glasses or any like high power glasses, and when the patient sits, make sure that patient is comfortable, like they should be sitting comfortably, and they should be usually their head or eyes should be in your level, and so that you do not need to stoop much, and the patient should look at the distance. That helps the patient to fix also. And if the patient is not dilated, then the pupil, when patient looks near, the pupil will be definitely constricted. So if patient looks at a distance, you have a bit higher chance of getting the pupil dilated and examining the eye. And when you are examining the right eye of the patient, you use your right eye. And when you are as I said, when you are starting this examination, you look from some distance and see the red reflex to know whether there is any media opacity, or whether there is a definite sign that the refractive error might be very high or very less, or there like is oil drop sign, etc. So ask the room to be darkened. This is very important. Even if you do not do anything, you have to ask the people to darken the room. And definitely in your body language, so that you are grateful or you appreciate that the candidate or the patient is helping you. Do not ever become angry. The patient may become cooperative, or they may be child, and or they may be old people. Do not become angry. So you have to practice your patience. This is very important. If you behave badly or something with the patient, then it is a definitely a wrong thing, and these are very taken very seriously by the Royal College. So you move the light closer, and uh, you can see the anterior chamber also, but these are usually not required. When if the media is clear, you go near the patient and you examine the optic nerve. What are the parameters you examine in optic nerve? Can any candidate please volunteer? Hello.
So we look at, sir, may I?
Yes, yes, Dr. Nana, please.
The optic nerve head, we look at the size, the shape, the margins, whether well defined or not. Then the cup disc ratio, the vessels emerging from the disc, and if there is hyperemia or pallor of the disc.
Okay, and also neuroretinal dream. You have to tell the
Okay.
IELTS see the regularity of neuroretinal dream, and if the ISNT rule is followed. What is the ISNT rule?
The inferior is the thickest, then superior, then nasal, then temporal. It is violated in glaucoma.
Yes, okay. And also you will see for any abnormal things like new vessels, etc. Definitely look for disc. So this is important. And after you examine the disc, you will look at the vessels and go to the macula. Why do you not examine macula at the first point in ophthalmoscopy? Can any candidate please volunteer? Like why do I
Patient
not?
will not be comfortable.
Yes. And
And it will
The
cause
pupil may
constriction of the
constrict.
pupil.
pupillary constriction. So these are the most important two things for which you need to examine the disc. So how do you ensure that you are looking at the disc when you are entering? What should be the angle between the patient's visual axis and your retinoscope light, but like ophthalmoscopy light?
We should come from a 45-degree angle, and patient should be looking straight ahead.
Patient looks straight ahead. What is the angulation between your light and the patient? That the question on the like the same question can be asked like how distance is the blind spot from the fixation? Where is the blind spot located? Which
15 degrees.
15
yes,
degrees.
15 degree. So the question answer is 15 degree. You will place yourself so that you are going at around 15 degree. That means 10 to 20 degree from the visual line or the visual axis of the patient. So then you see the disc, and then you go to the vascular arcade. And if you do not see the disc, you are seeing vessels. How do you go to the disc?
Raise the
Any
vessel towards the thicker, uh, look at the diameter of the vessel and follow the vessel
Yes,
Uh,
the vessel like branching will be there will be dichotomous branching of the vessels. So you go to the center because most of the vessels are coming, all of the vessels actually are coming from the disc. So this is the thing, and then you see for vascular abnormality, you examine the macula at the last, and you can see the periphery also. Some amount of periphery can be also seen in this. So and also definitely there are sometimes there may be multiple abnormalities which might coexist. So do not like stop doing stop like when you say see a single thing. So and whenever you are doing this, you tell the findings simultaneously. So this is like in clinics what I do. This is very simple. Obviously you switch off the light and you greet the patient and sanitize your hand. Then you go near to the patient, and for the right eye, because this light is less, so the focus is less. You have to formulate your own like rule, so that you examine the right eye or left eye first, and you follow the same rule again and again, so that whenever you are the things remain in your memory and you can repeat the same thing. So what are the limitations? Magnification is very high, so things appear larger, but you are looking at a very small field. And because you are going so nearer to the patient, it might be uncomfortable for the patient, and you need to reconstruct the whole image in mind, because you are not seeing the whole picture in the single image. So there is the images are two-dimensional monocular, and they obviously, if the patient has tuberculosis or some disease which is airborne, there might be a possibility of you getting infected. So this is if there is no light is coming in the retinal ophthalmoscope. So how do I proceed? Can any candidate please volunteer? There is no light. You are switching on the ophthalmoscope. The light is not coming.
The battery could be discharged,
Yes.
or the connection between the
we will
hand
share the notes,
and
please.
the head is not proper,
Yes.
or we have not switched on it properly, like it is not completely
Yes.
moved.
Yes. Any other?
The bulb can be fused.
Yes. Any other possible scenario? Any other candidate?
There can be, sir, in between change of filters, there can be
Yes. Yes.
maybe in between that.
Yes. That is very important. This is important. There sometimes even in my slit lamp, you are seeing this thing and you are not seeing anything, because the filter or magnification is in between. So that is a very important thing. So but in like the digital ophthalmoscope, it usually doesn't happen, but definitely you have to check the filters first, and then check for battery, bulb, charge, electricity, etc. And like you can like this is the bulb, halogen bulb, which is there in the and most of the time it is, if you practice it correctly, most of the times that no problem will happen. Ensure that you are, when you are starting examination, ensure that it is in zero, so it helps you really. Are there any questions regarding digital ophthalmoscopy here? So otherwise or we'll go to the
Yes,
next.
sir.
Hmm.
Sir, while doing direct ophthalmoscopy, how do we adjust for the refractive error of the patient? Like, is it done as we go closer to the patient, or how is it done?
So when you go there, like I said, you try to identify the refractive error right from the distance only. Because from the distance, when you look like with your naked eye, you might be able to see that, like at least guess that there might be aphakia. The problem is with both two things, high myopia or aphakia or very high hyperopia. So these patients will not, most likely will be given, but if they are given, the clues will be lying in your examination with the naked eye and examination with the distant direct ophthalmoscopy. When you are doing distant direct ophthalmoscopy, you will be, and this Bruckner reflex, those will help you in the finding the refractive error. And if you do not, even if you do not know, you just you go near the eye and you uh, rotate the dial. So if it is my myopic patient, when you go to the plus dial, image will be more hazy. So that will give
Okay.
you, and this actually comes with practice. It is rather than saying this, it will more come with practice. If you have to do it, even if you are
Okay.
not doing in practice, you have to do direct ophthalmoscopy in at least 100 patients. So this is one of the major take home points, that you need to practice all examination techniques yourselves. If you are not doing, then it is difficult. It is difficult to act. You cannot act before the examiners because you are in stress. So if you have been doing the same thing for 100 or 150 times, then it will come like in a flow. So this is important, and you need to do all these examinations by yourself again and again. So are there any other questions in direct ophthalmoscopy? So I think I'll go to the indirect ophthalmoscopy 20D lens. So what is this thing? What is the principle? So it gives a real inverted image. There are two plus lenses. One is the refractive apparatus of the eye, the cornea and the lens. And then there is a condensing lens, which is plus 20 lens here. And both of these will create a real and inverted image, which is a real and inverted image, and it is just between the condensing lens and the patient, like, and the examiner. So the magnification will depend on the lens used. Usually we find it by dividing 60. Like if it is 20 diopter, then you divide 60 by 20, it will be 3 times. So, and this is something which you need to understand. The upper part is light, and these two round areas, they are representing your pupil. So there is something called Coulston principle, which helps us to avoid the worrisome reflexes from cornea. So this says that the light and the pupils should be separated, but they when they are going inside, they should be separate, but uh, they should have a separate path. So just read about Goulston principle. So I'll not go into much theory. So what about the instrument? So we have to know the major things which we are using. So we are using 20 diopter lens. So what is the field of view in 20 diopter lens? Can any candidate please tell? So this is already written.
45 degrees.
Yes. And what is the 60-degree? There is something they have written 60-degree also, no? So why is it so?
Why?
What is 60-degree? So they have written 45/60 degree, no, 46 degree/60 degree. So why is it so?
When the eye moves, when the patient
Yes.
moves.
Yes, there is something static field of view and dynamic field of view. So, and this is most 20 diopter is the lens which is most commonly used. So you need to know about the magnification, which is 3 diopters, and the field of view, which is 45 degree, and dynamic field of view is 60 degree. So this is the most commonly used and which is the other lens which is used for ROP? For ROP, which lens is usually used? Any candidate? Retinopathy of premature.
28 April.
Yes, 20, Thanks, Dr. Aya. So read about, there is something called Volk catalog, Volk lens catalog. You can go to their website and you can see this. At least remember the parameters of the lenses which you have been using. So
Sir,
can you not tell which
Sir,
is what?
can
for
you?
ROP, what is the lens used? Couldn't get
28
it.
diopter plus 28 diopter lens.
Okay, thank you, sir.
Okay. Can anyone tell this why this white ring is there in the lens?
This
Should
has
face
to
the
be
patient.
Face the
kept on
patient.
the patient side.
This should be looking at the patient or the examiner.
Patient.
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 Why?
To
It's got
minimize the
something to do
reflection.
with the reflection.
Yes, it will reduce reflection. Like the other side will have less reflection rather than this side. If you keep this white side it will create more reflections. So, and this is the convexity is like this convexity of white side is less. You can see this.
Mhm.
This is the side in which white is not there, and this is the side in which white is there. So convexity is less in the white side, so it will create more reflection. So this is the lens. This is the So rheostat is there, and there are two levers which can change the size of the light, and also the color can be red, green, or blue. Why is this green light given? Can anyone tell us?
For getting a
red
red-free.
free image.
Okay. How does it help you?
RNFL defects
And
can
Also, it make
Microaneurysms.
microaneurysms more prominent.
Myelinated nerve
Appear
fiber.
black.
yes, basically, no, not myelin or fiber. Any the green filter will or red free filter will help you see anything which is red, and also the retinal nerve fiber layer. So hemorrhages, microaneurysms, etc. Microaneurysms are better seen in which device for microaneurysm.
Direct effect.
Direct
If a patient comes and if the examiner asks you just see screen this patient for diabetic retinopathy, or this patient has been diagnosed with diabetes, and he has been sent to you to screen for diabetic retinopathy. So which machine will you use? Which instrument will you use?
90D.
I
Yes,
would prefer slit lamp, yeah.
90D with slit lamp will be the 90D, or 78D with slit lamp will be the answer of choice. Do not say that you will use interior ophthalmoscope. If you use interior ophthalmoscope, you might be missing some fine or very minimal changes. So these are levers, and I think most of all of you have been using this, so they should know. And this is what I told you. The pupil of the examiner is seen in the below two mirrors. So this is like from the upper side there is a light coming, and there is a mirror which is uh, putting the light on the observer, and the two pupils or two eyes of the observer or examiner are coming to this through this mirror. So these are the, can anyone tell us what is this? This is there, and there is a round, large round and small round here, and this yeah. How does it do? Anyone can read it. What is the function of this?
It will change the size of the illumination.
I told the
In small
illumination.
pupil,
Small people. What does it do?
we
Small
can
people.
use the smaller beam, the smaller diameter beam to
Does it
visualize the
reduce the
content.
beam? Does it reduce the beam? Beam is reduced by this lever, the upper lever. See, this lever is reducing the beam size, like the diameter of the beam. What does this do? This line, this
concentrate all the beam into a smaller area.
yes. So what it will do, I have just kept this a. So look at this. When you rotate this, the all the light, that both the pupillary mirrors and the upper mirror which is reflecting the light, they will come together, or they will be in a smaller diameter round area. So that will help you in seeing the small pupil. But because the both the mirrors are coming together, the stereoscopic view will be reducing. So this is a similar mechanism is available in slit lamp. What is that called? To bring the pupil of the examiner nearer in a Huckstead model. Any candidate? Huckstead BQ 900. So am I audible?
Yeah,
Yes,
sir.
sir.
I don't know,
So
sir.
do you know of any mechanism in which both the pupils of the examiner can be brought a little closer? Like this mechanism is also bringing the pupils. Essentially, the mechanism is bringing your pupils together so that you can peep through a small hole or a small pupil. So some slit lamps, some advanced slit lamps will have similar mechanism. Can anyone tell us what is the name of the mechanism? So there is something called stereo variator. Just read about it and post it on the group. What does it do?
What is it, sir? Stereo?
Stereo variator. Stereo variator. STEREOVARIATOR. So many low-end microscopes might not be having, but Huckstead model is having that. So just read about it and tell us how it works. So, how should we go about this? And again, I have like copied this from the Chua book, because this is very important. Chua book is something which I'll request all of you to go through at least 4 times or 5 times before you examine, because this will help you in your exam and your clinics also, because they have given it very nicely. So obviously you introduce yourself, you have to examine the patient. This is very important. When a patient is coming to your OPD, you examine your patient for xanthelasma, how they are walking. And sometimes a patient might be having congenital glaucoma. One eye might be larger. So if you do not see them with naked eye, if you directly go to the slit lamp, you will uh, might not be having the clue. So that is very important. And patient should be examined lying, but in exam it is not possible. You can request, you can ask the examiner, sir, can I request the patient to lie down? Most of the time it will not be allowed. So then you examine the patient on sitting position, and you have to tell what you are doing. But in exam there will be not much time. So when you are doing in your own clinic, you have to say, you have to definitely greet the patient and then say, ma'am, I am going to examine this with this light. This light will be bright, and you might feel some watering or photophobia. That is perfectly normal. And what I do is I ask them to look at their own like thumb, and you can rotate it like 360-degree, left on left hand on the left side, right hand on the right side, so that you see. And sometimes you may tap the area gently, so that the patient usually looks that to that place directly. But you have to tell the patient. In examination it might not be possible because the time is less, and if you have been practicing this, it will come at a, but definitely darken the room. That is very important. Darken the room. And you have to adjust the instrument. You have to ensure that instrument is working properly. Show IPD you have to adjust, because there will be some other candidate who might have gone before. So the IPD will be definitely not adjusted. So you adjust it, so that, and close one eye and other eye, and see that both the eye are seeing us the same light, and it is not double, or they are not like, also they should be overlapping, and light intensity should be comfortable. There should not be much photophobia. And all of you know, I have told this lens, the white mark will be to the patient, and you examine the periphery first. Though it is for the same thing, if you examine the posterior pole, the patient will be patient will have difficulty, they will be uncomfortable, and people will constrict if the patient is dilated. And in exam, what happens that patients are there for a long time, and they have been getting examined. So after 3 hours, 4 hours, the pupillary dilation will reduce. So that's why many people have complained that pupil was not dilated. So that's not the correct like statement. That the people usually constrict because the time has gone by, long time has gone by, and there has been no supplementation of tropicamide or any dilating drop. So that's where your acumen will help. If you have been doing this for a long time, and you will be able to examine. But if you are not doing, then you will be in a trouble. So obviously the image will be inverted, but wherever you are looking, the things will be seen of that area. So if the patient is looking to the right side in the right eye, then you are looking at the temporal part. So examine the ocular structure in like vitreous, optic disc, versus macula periphery. What do you look in the optic disc or a vitreous? How do you examine vitreous? So if there is a question in Viva, how do you examine vitreous? In any in clinically, how do you examine any candidate? Please volunteer. This is just a mock exam. This is nothing. No, oh yeah, this is just internal thing.
To examine
Dr.
for the vitreous,
Yeah.
I look for the vitreous haze, whether the underlying retinal vessels can be seen,
Okay.
uh, disc vessels, then anything floating in the vitreous, like infiltrates or uh,
And are there other than interior ophthalmoscope, are there any other way to examine for the examine the vitreous?
slit
Direct
lamp 90 examination.
Okay. In slit lamp, what specifically will you see in vitreous? What
You can see
are the
vitreous cells in case of optic neuritis, Can see the vitreous cells in front of the disc.
In optic neuritis, typical optic neuritis, you might not be able to see the anterior vitreous cells because you are not able to see the posterior vitreous cells unless you are using a 90D. So do not tell that in optic neuritis you will be able to see retinal cells. The better answer will be I will be able to see retinal cells in intermediate uveitis or pan uveitis.
Yes.
Optic neuritis is usually an inflammation located in the optic disc itself, not like much, and the anterior vitreous may not be affected. So it might be seen in optic neuritis, but it is not a not a good answer in exam. So in exam, be very specific. Tell the only typical things which can be visible. So I am giving you a scenario. A patient is complaining of flashes and floaters, and in the vitreous you are seeing some pigment dot like things. So what is its significance? And these
Schaffer's
the
sign,
pigments are,
Schaffer's sign,
yes,
retinal
yes,
detachment,
yes. There might be retinal detachment or even retinal break
break.
might be there.
Yeah,
Yes. So if there is a pigment and there is flashes and floaters, what is the chance? What are the percentage of chance of the patient having retinal break or detachment?
75%.
Yes, 70 to 80 or more percent. So at least 70% to 80% patients will be having retinal break. So you'll have to examine that. So obviously in vitreous, you will look for clarity, like overall diffuse haze or any opacities which are there. Or for vitreous, you will have to, most of the vitreous abnormalities will be seen on the superior part or inferior part. Inferior part, because the gravity pulls everything down. So optic disc we have already discussed. You have to look at size, shape, margin, color of the neuroretinal rim, the optic disc, any other abnormality of an inner neuroretinal rim, and then you look at the vessel. For vessel, you will have to look at the vascular abnormality, and also if there is vasculitis, you look at which vessel is involved, vein or artery. And for macula, there might be multiple findings and periphery. So you have to look to have a like the patient should know where should look. Say you can ask them to like you can hold their hand and tell them to look at their hand or the thumb, or you can just tap them in this thing. Room should be dimmed. So this is I am saying again and again, whenever we are doing this, definitely request them to dim out the light. So obviously we do not stop if there is one more than one approach. So this is just a routine clinical case which I do. Just tell the patient into this and tell the patient what they should what is expected from them, and you just what I'm doing is just tapping it there so that he or she looks there. And see, what I am doing is I am rotating my head. Why am I rotating my head when I am seeing superior part? Can anyone tell?
to
When
get
I'm
the field of that side, opposite side.
Why if I keep my head straight, what will happen? Or what specific advantage does it give me?
Direct
The reduced
visualization
field
along
of
the
view
light rays.
and more reflexes will be seen.
No, the point is when the patient is seeing superiorly, the pupil is becoming oval, horizontally oval. Okay, do you agree or not? So, but the visible part of the pupil will be appearing like horizontal oval to you. So in that location, three things like your right eye, your left eye, and the light might not be able to pass through that area. So if you rotate or if you make your head horizontal, then the light and your one eye, here your left eye can go through the small pupil, and you can examine the peripheral retina, though it will be uniocular exam, but you will be able to see the periphery. Is there any difficulty in understanding this?
Yeah, sir. Can you please repeat?
Yeah.
So I have a photo. I'll show you. So I have it there. I'll tell you. So if the patient is having photophobia, how do I go about it? Patient is not opening the eye, not allowing to examine. So what should I do?
Reduce the
Reduce the
illumination.
illumination.
Yes,
And then maybe use topical anesthetic and a speculum.
yes, and
We can use filters also, green filter.
yes, illumination, you can reduce the light. So whenever you dilate well, you can like darken the room, examine periphery first. That is also important. and reduce the light. Light should be reduced, definitely reduce light. So, and examine periphery first, and then you can put a drop. How should I go about a small pupil? Small pupil, interior ophthalmoscopy in small pupil.
Dim the light
Yes,
and use that small pupil option on the indirect ophthalmoscope.
yes, the in the lower part, and also and
And
any other kind. So you what you will do, you'll darken the room, reduce the light intensity of the bulb or something, reduce small size. The size should be small. The small pupil adjustment lever which I showed, which brings the mirrors together closer, and thereby brings the pupils closer. You can use the 28 delineants which can see through small pupil and give a large ray. You can stand away from the patient. You can move your head away from the patient, and though moving closer to the patient increases the magnification, but it makes viewing through small pupil difficult. So you can, this is the small pupil which you through which you can see. So I am not able to see periphery. What should I do for increasing, improving the visibility of periphery? What are the mechanisms through which we can be helped?
The
Anything?
patient look to the either side, like look to
And,
the sides.
indentation.
and indentation, yes. Dilate oil, do indent, and you can rotate your, what I said, look at this. I rotated my head, right face tilt. So what it does is this is the pupil. The upper oval area is pupil, and through that there are two round areas. One is my left eye, and the other is upper light. So as I showed here, so these are the three things. This light, and there are two pupils. Can you see that?
Yes.
Yeah.
So when you rotate your head, so this is what happens. So the patient is looking up. So the pupil which is visible to you, it is actually now appears oval.
Yeah.
So
Mm.
in through this oval area, there the three that both your right and left eye and the light cannot pass through. It can pass through. You'll have to do the small pupil, and it is difficult. So if you have not used the small pupil function, you can just tilt your face to the right. So what happens is that light goes through that, and your left eye, the like mirror of the left eye, goes through that. The light or light ray. Then you can see with the left eye. You can see the periphery with the left eye. Am I clear here? No.
Yes.
So
Yes.
this is how like rotating your head may be helping you when you are seeing the patient in superior retina or the inferior retina. In the inferior retina also, to see the periphery, you might have to rotate the eye. So okay, so troubleshooting. So if there are double images, what would you do? You are seeing double images, the lights are, the two eyes are not seeing same thing.
Adjust the interpupillary
And
Interpupillary distance.
IPD. Need.
Yes, you adjust the IPD, and sometimes it's not possible. Like Dr. Manish had a class. I will request all of you to see that video. Also, it is in our Muthuswamy channel. So he was given an Indian ophthalmoscopy in which it was the two lights could not be mixed. Like they were, it was that the both lights were separate, and it was very difficult to examine. So there sometimes the instrument can malfunction also. If there is a difficult problem in the optics, then this can be there. But most commonly, such things will not happen to you, because other candidates will be seeing through the same mic A, and most likely it will not happen. If the light is not there, what can be this thing? There is no light.
Has to be charged.
Yes, and so before charging, I'll tell you to see the switch on that it, and check if there is any lever which is in between. So that is, the lever is one of the major causes in between. When you are examining, if you are seeing that slit lamp, there is no light, like you are not seeing the through the eyepiece, then there the filters or the magnification areas might be in between. Check filters, and sometimes there might be a cover, like the light, the area through which the light is coming out, there is a cover. So this also happens very commonly, and then go to the bulb or power, electricity, battery, etc., or switch. And this is the LED, LED bulb which is there inside the A. So what is the, here there is a bulb, and in the lower part there is a mirror, so which puts the light on the eye. So this is and also I'll request all of you, you'll be all of you having, will be having a like this thing, the Indian ophthalmoscope. You go and give some time to read the user manual which has been provided by the manufacturer. So these are some, yeah, and the most of these things will not be you will not be required to do prepare this, but just read at least. Just give it a look. So we have been using this Appaswamy Indian ophthalmoscope, which has been working very nicely. So are there any queries in Indian ophthalmoscopy with 20D?
Sir, is it mandatory that we have to look the periphery first? Because when we are telling for the exam, no, we will start with the disc. That is the order to go, no, sir?
Oh, you can go, but it is a for patient also it is a better thing. And sometimes the examiner will tell, like examine the posterior pole, or like examine the posterior pole and tell us what is happening. So if I'll say, if they ask you to give a look at the look with Index 20D, definitely start with periphery. You might not do all quadrants. You just see superior, inferior, nasal, and temporal. 4 times you see, but you see start with the periphery itself, because that that keeps your patient more comfortable. So once the patient becomes uncomfortable, you will also become uncomfortable. That is the fact, and you are in stress. And sometimes people who are in stress, they will be behaving in a way which is not acceptable. So that will create a much more problem. But it will not increase your timing. If you have been practicing with Indrid for a long time, even if you see like 4 or 5 times within the periphery and then see posterior pole, it will hardly matter. So, but I'll
Oh,
request you to examine the periphery first.
okay, sir. Thank you. Sir, then you told no about examination of the bit rays. So if such a question is asked, can we say direct with the +3 or +6?
Yes. That is another thing. Direct with plus power can be used to examine the vitreous also. Yes. So, and also if you are seeing through slit lamp, you can, if you the bit in vitrectomized eye, there will be like less vitreous in the mid vitreous cavity. There will be fluid. So that will also give you clues on what has happened. So, are there any other queries on 20D exam with this thing, Indian ophthalmoscope? So these are important. You have to practice it at least 100, and I think more than 100. You do examine all patients with Indian and 90D. And if you have been not doing in direct ophthalmoscope, you also do direct ophthalmoscope. These are these have to be done regularly, otherwise you will be in a trouble.
So do we carry your own direct ophthalmoscope to the exam?
You need not carry. If you want to carry, you can carry. I think they'll allow it also. But there is this thing. But if you want to carry your own direct ophthalmoscope and own 90D 20D, that is allowed in most exams.
Okay.
Okay, I'll go to the slit lamp bimodal with 90D lens. The principle is all similar like in direct ophthalmoscope. So instrument. So these are 78D and 90D. These are the two lenses which are used. So what is the
Sir, sorry to interrupt.
yes?
Just one more doubt.
Hmm.
In the idea, we are seeing it like inverted image. So so when we tell the findings, we have to, how do we report?
You have to tell it in a correct, like you have to reconstruct the image in your brain. So you
Okay.
have to tell when you are seeing the posterior pole, you are seeing the BRBO is looking inferiorly. Then it will be supratemporal BRBO. So
Okay.
you tell, like, you do not say that it is inferior BRBO. So you have to reconstruct the image in your brain, and you have to tell the correct location of the BR. And so it is easier to tell, like, till it is a BRBO. Sir, I can see a branch retinal. No, do not say the like short term. You say that, sir, there is a branch retinal venous occlusion, or there are hemorrhages in an OH shaped pattern in the involving the in suggestive or PR view. And then when they ask where, you can say superior temporal, or you can directly tell. But you need to
Okay.
reconstruct things, and you need to tell the thing correctly.
Yes, sir.
Can anyone tell us what is the magnification, image magnification of this thing? 90D?
1.3.
No, laser spot magnification is 1.3, image magnification is 0.76. So these are inversion, like in 1 by 0.76 is 1.32. So this is important when you are, the image is actually minified, and when you are putting a laser spot, it is magnified. So remember about plus 90D and 78D only. So this is the lens. So technique, I think everybody will be are doing. Obviously, greet the patient, sanitize your hand, then request the patient to ensure that patient is seated comfortably, and then you have to examine the anterior segment first, so that you know whether there is an opacity or not. It can take a little time, but definitely before 90D, it is a good practice, and in examination also, you just have a look of the anterior segment and then start. So, and then you bring the illumination to the center so that the light is there, and you examine. So limitation, if there is this in 90D also, you see, we saw that the image is magnified 0.76. How
Sir,
do how do I increase the size of the image? But I am seeing larger, no?
It is because of the slit lamp magnification.
Yes, it is because of the slit magnification. So slit magnification is used. Limited periphery view can be there. So you just dilate well, ask the patient to move their eye. And there are certain lenses which have very high field of view, which can be used in digital, like slit lamp, which has digital white field, super pupil excel, or super vitreofundus.
sir,
So troubleshooting
sir,
is,
I have a doubt.
yes,
Sir, while
yes,
examining the right eye of the patient, we use the left hand, no? While
yes, usually.
so when we examine the left eye,
Yes.
we use the right hand, right?
Yes, usually this is what we do. So as you can see, you have to keep on practicing this again and again, so that, so in the for the left,
But I use the same, I use the same hand
so
for both
yes, I use the same hand. So it is also okay to use the same hand also.
Okay, right. Thank you.
So, like you should be comfortable in doing this. But in detailed ophthalmoscopy, it is actually difficult to do with the other eye. It is not possible. So yes, I saw that I'm doing in the left hand only. So it is whatever you are like confident with. Troubleshooting will be similar like slit lamp exam. We are trying to, like, let's see if I get any other faculty to do this, or I'll do a class on slit lamp exam. So because slit lamp also, there are many people have faced problems. So books, obviously Kansky is important, and this we have written an article on auxiliary lenses in slit lamp exam. And self-assessment, there are multiple America Academy of Ophthalmology One network. You can go, and there are multiple MCQs in which you can actually do self-assessment. Are there any queries?
Sir, while introducing, can we say I'm Dr. So and so like that?
I think it's not required. So you just, ma'am, good morning. But you just say good morning, ma'am, or good morning, sir. I want to examine. Can I go ahead, or I'll be examining you with this with this light. You will be feeling some photophobia. Should I go ahead?
Okay.
Most of the time, the examiner will say that there is no need. You go ahead with this. The
Okay.
patient, they will say that patient has been explained about everything. You just go ahead and you tell your findings.
Okay, sir. Thank you.
And time is so less now, it is very difficult
Yes.
to do anything. Books, write many things, but basically what they see is how, whether you have been practicing it in your practice or not, and whether you have the courtesy, the professional courtesy which is expected from each doctor to the patient. Like, you should respect the patient. You have to understand that there are 50 more candidates who have been examining them, and they have been like, they have, like, when somebody does Indian ophthalmoscopy, if you have undergone the same exam yourself, you know that how difficult it is for the patient. So sometimes candidates have become very angry and they scolded, or they sometimes candidates have hit also the patient. So which is extremely bad behavior, and not professional at all. And if you do that, you will definitely fail. Nobody can pass you. So are there any other questions? So because I thought of taking it very crisp so that the major question queries and things are answered.
So are we ever asked to draw the retinal drawings?
No, most likely not. So they'll ask you what is there. So there'll be no retinal drawing, no written, no. It is a good practice to uh, draw retina in your practice. But more in examination, most likely it will not be allowed or not be given.
Okay. All right.
Sir, not only in retina, all other examination, do we have to write it down or just have to keep
No, no,
on
no.
telling an exam?
Just when you are examining, you just tell like, sir, I am seeing this and that.
Yeah.
And another thing is sometimes people discuss outside that there is a penetrating keratoplasty here. I think this is DSEG, etc. And you fix your mind with that. You think that it is DSEG and you try to
Mm.
the diagnosis itself, and then you either try to match the findings. Do not do that. You say whatever you are seeing and then go to the diagnosis. So this is one major thing. You just focus on the findings which are there. Do not try to match with a known diagnosis or match with something which you know or which you have been fixed with. So this is something wrong. So that's why it's not a good idea to discuss with other candidates about the what is there inside.
So can you explain once more how to look for the posterior vitreous cells?
For posterior vitreous cells, you'll have to look at the with 90D. You keep the slit and you focus on the like lesion. Usually it is seen in retinitis cases. So when there is retinitis or chorioretinitis, you focus on the retinitis lesion, you will be able to see white cells in front of the retina itself. So these are more prominently seen on OCT. So also vitreous cells, vitreous like architecture of vitreous is important in intraocular lymphoma cases or the hereditary vitreoretinopathy cases in which the pattern of the vitreous might be difficult. Somebody please read about the patterns of vitreous in like the Stickler syndrome type, various types of Stickler syndrome, and post the images along with their type like membranous, fibrillary, etc. So if there are no queries, I think we can close. So I think that classes should be not more than 1 hour because our attention span might also reduce. So are there any other queries?
Yes, sir.
No,
Thank you,
sir,
sir.
we are
Yes,
actually exam
definitely.
going batch. Actually, we request you to conduct more mock exams in the coming weeks, sir, if
Yes,
possible.
we have told we have already contacted few of our faculty members who will be conducting this,
And
and
one
also
more, medicine. If Vijaya Pai ma'am is able to take
yes,
one class.
for that you will have to write on the group. I'll post on the group
Okay.
people who are interested in to have a class on medical aid, please tell. So you put your name. So if there is more than 15 people, so we can definitely do that also.
Okay, sir. Okay, sir. Thank you, sir.
Thank
So
you, sir.
Thank you.
and
Thank you, sir.
if you have
Thank
benefited from this, it is
thank you,
a
sir.
good
Thank you.
good day to express your gratitude, which will give you inner peace and happiness. Thank you. Good
Thank you.
day.
Thank you.
Best wishes.
Thank you.
Thank you, sir.
Bye.